In my previous video, I talked about a case of ankylosing spondylitis and raised an important question. Who is responsible for providing comprehensive care for such patients? We discussed that rheumatologists, or physicians with specialized training in rheumatology, play the primary role in managing these cases. At the end of that video, I mentioned that the patient chose to visit an interventional spine pain specialist instead of the recommended rheumatologist, assuming his issue was only lower back pain. In this video, I will continue the story to highlight why an accurate diagnosis, clear patient communication, and referral to the right specialty are essential. I'll share the link to my previous video in the comments section for your reference. After the patient visited the interventional spine pain specialist, I discussed the case with the pain physician and again advised the patient to see a rheumatologist. Following our recommendation, he finally consulted a rheumatologist. Once the diagnosis of ankylosing spondylitis was confirmed, the rheumatologist ordered a few investigations in preparation for starting biologic therapy. When his tests for tuberculosis and hepatitis B and C came back negative, he was advised to begin treatment with adalimumab. However, the patient hesitated and chose not to start the injectable medication. About 6 weeks after the therapy was prescribed, but not initiated, he suddenly woke up one morning with severely reduced vision in one eye. This vision loss was due to uveitis, a common and significant extraarticular manifestation of ankylosing spondylitis. Acute anterior uveitis can present with sudden, painful, light-sensitive inflammation in one eye, affects 20 to 30% of patients, and can sometimes be the first sign of the disease. If not treated promptly, it may lead to vision impairment. What might have happened if, instead of seeing the rheumatologist, he had continued his lower back pain treatment with the pain physician? In that scenario, his management could have been diverted away from the necessary systemic anti-inflammatory therapy, such as biologics, and focused instead on localized steroid injections. It is also possible that when he later developed vision impairment, even the ophthalmologist might have missed the underlying cause. The possible reason the ophthalmologist could quickly identify the problem and start the right treatment was because the diagnosis of ankylosing spondylitis was already known. What if the patient had started the prescribed medication? In that case, he might not have developed impaired vision at all. This case highlights why making an accurate diagnosis and referring the patient to the correct specialty for comprehensive care, rather than offering only symptomatic relief, is absolutely essential.